All right, everybody. This is an interesting case we had recently that spans two of our ERs. Kind of an unfortunate outcome. The highlight of this case is one of the critical things I want you to learn from me, and that's that STEMI is an irrelevant term. We should change the way we're thinking. It shouldn't be criteria set forth on certain measurements. It should be, does this patient have a pathological amount of coronary artery disease and doesn't need emergent intervention? Okay, like the thing is, asking does your patient have coronary artery disease is like asking does your patient have age? Like the answer is yes to both. Like yes, like every patient has coronary artery disease. Like we all have coronary artery disease. Like back in the Korean War, they did a bunch of autopsies on these young kids that unfortunately died in the war, and they found they already had the beginnings of atherosclerosis. Like it wasn't a pathologic amount, but they already had the beginnings, right? So we all have coronary artery disease. The question is, well, how much do you have? So in the ER, when someone comes in with chest pain or some kind of chest pain equivalent, that's the thought process we should have is not does my patient have coronary artery disease? The question is, well, is a pathological amount of coronary artery disease causing the presentation of my patient? And how do I need to fix this? And the answer is soon. Okay, so let's go over this case. So patient arrives to the ED complaining of chest pain. Patient states the chest pain is constant pressure pain that has been present for 20 minutes. The ER doctor evaluated the patient immediately upon arrival. Let's see. So past medical history, hyperlipidemia, history of coronary artery disease, like history of a stent. Okay, so I forgot to put the age. I believe this patient was 73 years old, so relatively high risk, right? Age, risk factors, known coronary artery disease, and presents with chest pain. Okay, so as we should always do, a good idea is to get a baseline EKG. So this is a EKG from 9 months ago that I found for this patient. So let's just go through it to practice our steps. So we got the rhythm strip down here, and I see 1P before every QRS. Okay, so we have sinus rhythm. The rate is not fast. Okay, you might be tempted to call this a AV nodal block because it looks like there might be like a blocked P wave in there. That's not the case. Okay, for two reasons. Number one, the morphology is different. Like these P waves look different, and the PDP interval is not the same. Right? Like that's one of the things for a AV nodal block is the PDP interval like shouldn't really change, and the PDP interval is if these are different P's, right? Like this interval from this U wave to this P wave is different from this P wave to this U wave. So that's how this is a U wave, not a dropped P wave. Okay, so normal sinus, good rate for access. It's up in AVF and up in lead one, so normal. For intervals, the QRS, let's see, we got about 2.5 boxes, so not 3, so not wide. The QT does not look prolonged. So let's look at our ST segments. I always usually go to AVL first. Okay, it looks flat. Yeah, I don't really see anything obvious there, no J-point deviation. Up here in lead one, there's a little bit of artifact here, but I don't see much J-point deviation. The T wave is upright, which is normal. Here in 2-3 of the F, maybe a little bit of enlargement of the P wave, but nothing crazy. I don't see any J-point deviation in these leads. The T waves are upright, which is normal. Okay, there might be a little bit of a fractionated QRS here, seen in 3 in AVF, which can be sign of structural heart disease, like a valvular issue. Up at AVR and lead 1, I don't really see any J-point deviation. Okay, the T wave is inverted in AVR, which is normal. Technically this T wave should be inverted. It's upright, which is not really pathologic. We don't really have, anytime I see an upright T wave in lead 1, I always go look at lead 6 and make sure that the T wave in V1 is not bigger than V6. It's not really here. Technically this upright T wave is abnormal, but I wouldn't say it's pathologic. But I digress. Again, contiguous leads, V1, V2, V3. I don't really see any J-point deviation. The T waves are upright. We got pretty good R wave progression here. Same thing over here in V4, 5, 6. I don't really see any J-point deviation. T waves are upright. That looks good to me. So overall, I don't really see any pathologic process. I would say this is like non-diagnostic, just a EKG for baseline. Okay, so now we have the EKG when the patient arrives at 2246. Okay. Again, recommend you go through it on your own, but here's what I see. Okay, again, just go through the process here. Down here for the, where's my pen, rhythm strip. I see 1p before every QRS, case of sinus. Rates relatively normal to a little fastish. There is some irregularity in the R to R here, but there's still 1p before every QRS, so it's sinus, okay? The axis is up in AVF and up in 1, so normal, okay, for intervals. QRS duration, let's see here. Is this wide? There's the beginning of it. No, it's still like less than 3 boxes, so not wide. QT does not look prolonged. Okay, so let's look at our ST segments. Okay, first of all, note the new T-wave inversion in AVL. Okay, not only note is it inverted, but note how linear it is. Okay, look how straight this line here is. And also look at how straight this line is compared to the amplitude of the QRS. Like this, the amount of this linearity here is definitely greater than 1/4 of the amplitude of QRS. That's always concerning for me. Okay, again, that's another thing. A big rule that I think you should take away is anytime you see new T wave inversion or ST depression AVL in the setting of chest pain or any angina equivalent, a huge red flag should go up. Okay, so now I look at my contiguous leads for my ST segments and T waves. The contiguous leads I use is AVL and lead 1. We already know the inversion. Up here in lead 1, we do see a little bit of J-point depression, maybe like 0.5 millimeter, okay? And also we see this linearity of the ST segment here. We can see there, and we can see it here too. Like here you can see about 0.5 millimeter of ST depression and ST segment linearity. Here in 2,3 AVF, I do see some J-point depression here in these leads, maybe like 1 millimeter to 0.5 millimeter. And again, I note the linearity of these ST segments here. That's always concerning. AVR and V1 are the next contiguous leads I look at, and I do see J-point elevation of like 1 to 1.5 millimeters in AVR, and I do see it over here in V1. We got about 1 millimeter of elevation in V1 as well. Now, technically AVR and V1 are not the classic contiguous leads, but for me, I do use those as contiguous leads when I'm looking for focal repolarization abnormalities. Also note the linearity of these ST segments in these leads as well. And also note like the amount of linearity here is concerning because it's greater than 1/4 of the amplitude of the QRS. Then down in V2 and V3, I don't really see much J-point deviation. Over here in V4, 5, and 6, I do see some J-point deviation of about 1 millimeter, and I do see some linearity of these ST segments here. So overall, my interpretation is, okay, so technically you can't call this a STEMI because in North America we don't use AVR elevation as a STEMI or semi-equivalent, and technically AVR and V1 are not contiguous leads. So for me, this is indicative of an infarct, but overall this EKG is highly concerning for active ischemia, okay? Remember, ST elevation and ST depression could be from other things that could be suspicious, causing this pattern. Suspicious elevation in AVR and V1 would be suspicions for a pulmonary embolism as well. Again, but he's not tachycardic, no right heart strain, so I would doubt that, okay? So that's my overall opinion of this EKG. So what happens with the patient? All right, so here we go. Patient had EKG done immediately upon arrival. EKG evaluated by the ER doctor. Slight ST depression and diffuse leads. Patient states back pain or pain raised to his back. Patient's blood pressure evaluated bilaterally and is near equal. Bilaterally, they did that because they're concerned, could this be a dissection? That doesn't 100% rule it in or rule it out, but that's cool. Patient given 1 sublingual nitrile per the ER doctor. Nitrile was placed under his tongue. As soon as the nitrile was placed, patient became unresponsive with no pulse. CPR started and epinephrine given. Patient started to moan during CPR. Patient's pulse checked and pulse present. Patient started to speak and then became unresponsive again. Epinephrine again given and CPR started. Patient started to moan and make purposeful movement during CPR. Pulse checked. Patient had pulses and started to speak. So he was dead and he came back to life. Project Lazarus. Patient's rhythm evaluated. Patient was in VFib. Patient shocked twice. Given 150 valvular bolus and drip started. EKG repeated. STEMI activated. Heparin bolus and drip started. Patient spoke to Dr. Blank, STEMI cardiologist. Dr. Blank evaluated the EKGs pre-VFib arrest and post-VFib arrest. Asked for a 4th EKG. Did not believe that it was a STEMI. So flight arrives to take the patient to Toledo. In the meantime, suggest a CTA to look for PE. We get the CTA done. There's no signs of a PE or dissection. Patient goes to Toledo. So he goes to Toledo. He's awake and he's talking and he has a pulse. So good job. Like, good job, ER. Guy came in. He died in front of you. Brought him back to life. Nice work. A couple of things here. I mean, that's why for the protocol, they always like to have an IV before you give someone sublingual nitro. And the most important thing for any arrest is, the time to onset to treatment, specifically chest compressions. So good job. All right, so here we go. So here's his EKG when he shows up at there's an EKG afterwards, 2250 after they get him back. Let's take a look at it here. Okay, so what I see in the rhythm strip is normal sinus rhythm, 1P before VQRS. Again, some variation of the R to R, but there is 1P before VQRS, so still sinus, so I don't care about that. The rhythm rate looks relatively normal. Up in AVF, up in 1, so normal access. For intervals, again, it looks like it might be kind of wide here, but when we go through and look at this, let me see, 1, 2, it's 2.5, still less than 3 boxes, so it's still not wide. And the QT interval looks good to me. So now let's look at our ST waves. Again, I usually start in AVL. Again, here we have this inversion and linearity of the ST segment. The contiguous leads I look for as far as J-point deviation and T waves is AVL and 1. We already saw the inversion. Again, here we see the slight depression and linearity. Again, in 2-3 AVF, we see the slight depression and linearity in these ST segments. A little better in lead 3, okay, but we can still see it here in lead AVF. Again, contiguous leads here in AVR. I'm still seeing this elevation, and I'm still appreciating this linearity. In AVR and V1, okay, look at this linearity. And again, look at this linearity compared to the QRS. Like, it's definitely greater than 1/4 of the amplitude. V2 and V3, maybe some J-point deviation there, like 0.5 millimeter to 1. Not much here in V3. Over here in V4, 5, and 6, I am seeing some J-point deviations, particularly J-point depression. And again, this linearity here of the ST segments. Again, so this is still concerning for me for active infarction and definitely ischemia. We still have those same symptoms or same abnormalities as before, which do appear to be improving somewhat, which is reassuring. But again, my opinion as far as spontaneous resolution of ST segment elevation during acute coronary syndrome is irrelevant. From what I've read, again, it's not conclusive data, but resolution of the ST elevation during STEMI is not always a good sign, and that the people who have resolution of elevation still have the same amount of coronary disease and still have to do the same amount of intervention. I mean, they do better overall than people who don't have resolution, but they still need to be intervened on. Here we have some more EKGs. Look like they were post-arrest. This one's kind of difficult and sloppy for me to see what's going on. Do my best to see here. So here in the rhythm strip, I see these 2 consecutive wide beats. It's not enough for me to cause VTAC because it's not more than 3 seconds. I don't see a clear, I see a couple P waves in here, but no real correlation with a QRS. So for me, I don't think it's atrial fibrillation or flutter. I'm seeing frequent PVCs, lots of ectopy. Some of these are narrow, some of these are wide. The rhythm here, I would say this is I'd say indeterminate rhythm. I can't determine this at all. It's not VTAC, it's not sinus, it's not fib or flutter. I have no idea what the rhythm is. For the axis, I do think it's up in AVF and overall down in lead 1 more. So we got some right axis deviation, which is always concerning. Okay, I could say you can make the argument that this is an intermittent ventricular escape rhythm, like an accelerated intraventricular rhythm. But I don't know. I'm not an electrophysiologist, but I digress. So as far as ST segments go, again, hard for me to tell, but in this native beat right here, we still see this inversion and depression here. Hard for me to tell if there's J-point deviation because it's way too wide. Sorry for intervals. As you can see, it's definitely wide. Again, we have these different morphologies. We have this down one here, this up here, these alternating ventricular, those are PVCs, accelerated intraventricular rhythm. I have no idea what to make of that. Again, difficult for me to tell if there's J-point deviation here. There's still some concerning signs up in here in AVR and V1. Overall, impossible to tell exactly what's going on. Most important thing is it's good that the patient has a pulse. Again, another EKG a little while later. Now we have sinus tachycardia with a normal access. Again, incomplete left bundle branch block. I still see some diffuse J-point deviation and T-wave abnormalities, but again, no acute infarction here, just non-specific abnormalities. I imagine this was after the epinephrine. Here's an EKG when we get to Toledo Hospital by flight. This looks much better. Again, you can see there's multiple abnormalities here, but the ST depression looks better, the elevation looks better, the T waves have flipped back up now. Again, all looks improved. Again, resolution of those problems. But for me, in my opinion, that doesn't matter. It still needs to go to the cath lab, right? So, patient gets to Toledo Hospital, evaluated by a cardiologist. They're like, yeah, I agree, it's not a STEMI. We'll cath them eventually. So patient does well. He has unheparin and amiodarone. Here's the results. Look at the troponin, 8 to 3,000 to over 4,000, back down to 1,900. So a couple days go by, I think 3 days go by. He gets an echo prior to going to cath, and it doesn't look good. We got an ejection fraction of 25 to 30. We have all these wall motion abnormalities. Look at 3 is akinesis. Look at all these areas of akinesis and hypokinesis. What if you say, hey, Patrick, that's how his heart hours is. That can't be from this. Well, I have a echo from 9 months prior. And then we had an EF of 55 to 60. And look at all these nice, beautiful blue ones here, these normals here. So it goes to cath, and there is coronary artery disease. Okay, no complete occlusion, but you can see there's some pathologic process here, diffusely in the LAD, okay, both proximally and distally. Again, patches of problems here in various degrees of coronary artery disease, again, but no complete occlusion. There's also some in the RCA, but I couldn't get a good picture of that. Here's the cath report, multi-vessel disease. The thing here is, the plan here is to treat this medically, and they say, if he develops arrhythmia and chest pain, maybe we can think about revascularization. What worse arrhythmia is there than VFib arrest? Like that's the thing is, yes, I agree with the statement, this doesn't qualify for a STEMI, but let's look at the patient. They're high risk. They come in with symptoms. They die, in front of us. They have an abnormal EKG. I don't care if it resolves. We know it's not a PE, we know it's not a dissection, the QT's not prolonged, it was VFib. Let's go to the coronary arteries. Why should we wait? But, I digress. And that's the thing, here, why I want everyone to think about, we shouldn't think about this as STEMI. We should think about, well, does my patient have coronary artery disease, and do they need emergent revascularization? And there is some, pathway through the recommendations that does kind of point to my argument being correct. Okay, so here's the science and the data. Sorry, I got a drink. This is from the 2025, all the academic nerds' recommendations, and here's what a STEMI is. So if you ask me, well, what's a STEMI? This would be my most current answer. Okay, so STEMI, new or presumed new ST elevation of greater than 1 millimeter in 2 anatomically contiguous leads, measure the J point in all leads other than V2 or V3. So that means any leads besides V2 for V3, you just need more than 1 millimeter in 2 or more contiguous leads. So for V2 and V3, you need 2 or more millimeters in men over 40, more than 2.5 millimeters in men under 40, and over 1.5 in women, regardless of age. Okay? So that's what the criteria for a STEMI is. So did this patient have that? No, they did not. Okay. They did have EKG abnormalities, though, which do fall into the non-ST elevation / ACS abnormalities, correct? New or presumed new, and usually dynamic, horizontal, or downsloping ST segment depression of greater than or equal to 0.5 millimeters in 2 or more contiguous leads in end or T-wave inversion greater than 1 millimeter in 2 or more contiguous leads with prominent R wave or R to S ratio greater than 1 or transient ST segment elevation. So this guy did have, I mean, we have these ST depressions and inversions and stuff, and also transient ST segment elevation. This prominent R to S ratio greater than 1, I guess he does have that, but I usually don't use that or know about that. I mean, that's what he has, right? Like transient ST elevation, AVR and V1. Again, like they said, linear or horizontal. J-point depression more than 0.5 millimeter in contiguous leads. And again, like AVR and V1 are not classic contiguous leads, but those are the contiguous leads I use. Like when I'm looking for these for ischemia infarction, that's what I look at. First I look at AVL, and then I look at these contiguous leads to look either for hyperacute T waves or J-point depression. And the leads I use is AVL in lead 1, 2, 3 AVF, AVR in V1, V1, V2, V3, V4, V5, V6. Like that's how I look at it, and that's how I like screen EKGs. So here we go. So here's, within the recommendations from all of the specialists, there is a pathway to make an argument for emergent cath for these people. So this guideline will focus on the acute management of ACS, including unstable angina, non-ST elevation, and STEMI, which are presumed to result from atherosclerotic plaque rupture or plaque erosions and subsequent thrombosis. Under the universal definition of MI, these MI events would be classified as a type 1 event. That's what I'm talking about, right? Like that's the question I posed to you initially. Like when you're seeing your patient, it's not does my patient have coronary artery disease, it's how much do they have. And when you have this trifecta, in my opinion, of symptoms, risk factors, and focal repolarization abnormalities, the terms don't mean anything. Whether it's STEMI, that doesn't matter. Like you have a high pretest probability for having an acute rupture or an acute process that needs intervention as a type 1 myocardial infarction, right? And that's what we're worried about, right? Like the main ones that we're worried about are how to treat, is it a type 1 or a type 2? Here's the other ones which you can read out, type 4 and 5, like we cause and stuff like that. Again, more guidelines and stuff from the specialists. Again, you can read this at your leisure. But the important parts I highlighted, those with a witnessed arrest and shockable rhythm have improved survival. Outcome for patients with STEMI who are awake after resuscitated cardiac arrest are comparable to patients with STEMI who were not in cardiac arrest. For this reason, patients with cardiac arrest who have achieved return of spontaneous circulation and are awake with STEMI on EKG are candidates for PPCI. Which this guy kind of fell into, right? Like he was a witness arrest and he had return of spontaneous, like he was awake and talking, he wasn't intubated. And that's the other question, which I won't go into detail here. But after, someone arrests and you have return of spontaneous circulation, the question is, well, who benefits from emergent cath and who doesn't? And in general, my summary is someone who's, is going to have a good outcome and it's not super sick to begin with, that's the person who you should cath. Like, someone who's been down for a long time and, they have a GCS of 3 and their pH is 7.1, like that person is not going to do well and the cath is not going to improve like their outcome or their survival. But a person like this, who, had an arrest, like their heart stopped and now they're awake and talking to you, like they're salvageable, they're going to have a good outcome. So this is a person who we should not be sitting on, like we should be emergently cathing this person. And this case highlights why. Like when you wait, you lose all the benefit of time. Okay, and again, like what I was talking about before, more in the evidence of the pathway as far as carving out, well, yeah, I know this isn't a STEMI, but this person like still needs to go to cath emergently. Okay, here we go, like level 1, recommendation B. Patients who have been resuscitated after cardiac arrest and who are non-comatose or who are comatose with favorable prognostic features and with evidence of STEMI should undergo PPCI to improve survival. This is what our patient had, with the exception of the STEMI. If you're saying like, well, what are the criteria and stuff? He didn't technically meet STEMI, but again, like people who have a good prognostic outcome who are salvageable, those people we should be like urging for an emergent cath, like in this patient. Here we go, more level of recommendations. Here we go, 1BR, okay, in patients with ACS and cardiogenic shock or hemodynamic instability, emergent revascularization of the culprit vessel by PCI or CABG is indicated to improve survival, irrespective of the time from symptom onset. Like this is where our guy is, right? How much more hemodynamically stable can you be than dead, right? Like that's what happened to him. He had a VFib arrest, he had no pulse, like he was dead, and then he came back. Like, that's cardiogenic shock, hemodynamic instability. Like, yeah, I know it doesn't meet STEMI criteria, but this person should be cath right away. And you can see what happens when we don't in this instance. And that's the thing is, I'm not placing blame on anyone. STEMI was called and, reviewed and said, well, yeah, it's not a STEMI. And the patient was evaluated by cardiology again at Toledo's emergency room. And again, I'm not placing blame on anyone, but, that's what one of the things I want to talk about or brought up this case for is why I think we should be rethinking how we think. Like, well, yeah, I know it doesn't meet STEMI criteria, but look, what's going on here? This person is critically unstable. They had a VFib arrest, chest pain, high pretest probability, and abnormal EKG. Let's go cath them. So that's all I have for this EKG or this case in summary. Hope you liked it. I turned on the comments on YouTube, so if you have questions, you can try to comment on there if you want or ask me in person. I'll try to respond to the video if I can. That's all I got. Peace out.